People can hear me, right?
Yes.
All right. Perfect. Thank you all for your patience. So we're talking about regression. Everything should be up to snuff now. Everyone in the room can hear me. So quick definitions. Regression, loss of milestones. Global developmental delay is not going to be in the ICD-10, or sorry, ICD-11. I just want you guys to know that. So there's going to be a change, at least as it's currently set up. It'll be called Disorders of Intellectual Development Unspecified. You can also interchangeably use currently static encephalopathy with global developmental delay. After 5, don't use global developmental delay. You should transition over to intellectual disability type diagnoses. So DID is what you should transition over to, which we're about to talk about. And childhood disintegrative disorder is subsumed under ASD, but it's sort of like a more severe autistic regression that occurs a little bit after 2 years. So just continuing definitions, it's a busy slide here, but I wanted to talk about the origin of IQ for a second, because I think it's important if we're going to be using these metrics to understand their limitations. So basically, everything is disorders of intellectual development going forward. And the old way was using IQ testing, which was actually it was like coined in the late 1800s in Germany for school children as a way to assess how well they're performing. And then it was picked up by Stanford University at the turn of the century and applied towards people in non-school settings. So they basically took school type tests and they applied them to the general public, some people who have never been to school. And they did this in a way to sort of segment and understand who is a better performer and worse. But really what they were assessing was, are you good at taking tests? This is a test on, are you good at taking tests? This is not a test on, can you function in society or are you social? So in like the 1920s, it was used to justify the eugenics movement in the United States. And we actually sterilized 60,000 people, over the course of decades because they were, quote, imbeciles or morons, or these words were like, used by scientists and put in law. And they were so persuasive that Hitler actually used them as justification and used IQ scoring to justify, extermination and things like that of people. So I want to bring that history just so that you understand IQ is not like that great of a metric. But on top of its dark history, what's interesting about IQ is that it doesn't really give you conceptual domain. It doesn't really give you social domain or practical domain. So the new way is the better way. That's the Vineland. And that's what we're using now. And then there's also the Wessler and ABA S3 and several others. But those are going to actually be more applied in their assessment. They still use standard deviations. It's the same technique. So mild is 2 to 3 standard deviations below the mean, moderate 3 to 4, and then severe is greater than 4, and then profound is greater than 4 standard deviations below the mean. But in addition, they have very little to no practical or social domain fulfilled. So that's what makes it profound. So that's enough about this. I like this quote. People who boast about their IQs are losers, from Stephen Hawking. So I'll leave that with you. So what are we talking about? That's just intellectual disability. But what we're really here to talk about is regression. So I point out these different trends in the graph for how someone can, develop. Intellectual disability may be something more like this, a non-progressive insult early in life, like, hypoxic brain injury. And then we plateau sort of into adulthood, not as well as we could have if we didn't have that insult. Developmental regression itself is that we had normal development, and then we lost milestones. And so the only people who have really studied this formally, at least over the last 30 years, has really been England. And they did a large study using basically all of the sample from their medical, service, like all the children that are a part of their healthcare system, to find children under 16 who all three of these things have progressive deterioration over 3 months, lost already attained skills, and developed an abnormal neurologic sign. That's what progressive intellectual and neurologic deterioration is. And that's what we're really calling regression, like true regression. You lost your milestones and you developed a new focal neurologic deficit. And we exclude static loss, encephalopathy, drowning, stuff like that. What they found, and I'll just have you focus on the graphs over here, was that when you do all that, you actually come up with, basically a list of leukoencephalopathies and sort of storage disorders, where what happens is you result in a dementia, whether that be peroxisomal or gangliosidosis, mucopolysaccharidosis, or mitochondrial disorders or NCLs. Those are the ones that come up, and it's pretty interesting because over about 30-year period, they found 2,500 people who fell into this category based on that criteria. And that in addition, they basically found the answer for about 90% of the people. Only 10% were undiagnosed having this regression. And they did so, towards the end of it with whole exome, but in the beginning of the study, it was based off of a lot of those metabolic labs. So I think that's just like, it was an important study to figure out what is really causing this deterioration. You have your guys, so it's probably one of these if you see a true deterioration. So I also want to articulate really that autistic regression is not pinned. So autistic regression does not include new neurologic exam findings. That's going to be a very important piece here. When you look at autistic regression, it's actually a pretty fascinating, heterogeneous type of condition. It occurs in 32% of children with autism. So I want that to be understood, that it is actually very common. And the onset is usually at 19.8 months, 20 months old, somewhere between 1.5 and 2 years old. They lose language, they lose social. If you look at these graphs here, you can kind of see it, that basically this domain right here is social, speech, and there's full loss, which is definite, and subthreshold loss, which is definite. So the blue and the green indicate that basically language is completely lost. Like whatever was there is now gone. They were functioning at 15%, compared to a normal kid, and then it's gone, right? So that's what occurs when they're 1.5 years old. But all the other domains, in 30% of autistic kids, but all the other domains are preserved. And that is important for when you're screening these children. So you'll notice that even their social actually is pretty well maintained. Their social is the only thing that's lost. Excuse me, that's what I meant to say, because it has full loss. So the social is lost because it's the only way to be social is in a lot of ways is through communication. You can use nonverbal, but it's difficult. But their motor and fine motor self-help skills stay roughly the same. They don't lose very much. So to summarize this again, in autism, 30% of kids lose language and social. Then they regain it after about 2.5 years. So at 5-ish, they'll have that back. And that's 92% of them will get all their language back. And then also less than 1% of these kids, these autistic kids, actually continue to lose milestones. And perhaps they're the ones that fall into pinned. Does that make sense for everybody? Okay. So here's another kind of thing that I just think is important to understand where the field is going with regard to regression. So there's 1,068 genes that are responsible for, autism, according to, the Safari database, which is, the Siemens Searchlight database. And then you can see that up here in the upper right corner. The red ones are most, confirmed and syndromic. And then, orange in the upper right is, they're very sure, but not 100%. And then, it kind of goes down from there. When you think about what do these genes do, right? I break it simply into two things. These 1,000 genes, they either help with transcription or they help with synaptic functioning. That's what they do, right? You can talk more about that in a lot of detail, but let's keep it simple like that. So when it comes to synaptic functioning, there's a subgroup of people with postsynaptic density mutations. The other side of the synapse, the postsynaptic density, is the area by which all your receptors anchor. And all the celeb receptors like, dopamine, NDMA receptors, AMPA, you can see them all there. They all link on this big raft and they live on the postsynaptic density. It's very important that stays stable. When that breaks down, when there's mutations that lead to a failure of it to function, you actually predispose the development of autism and that of regressive autism. And that's what you see over here when they're saying that, about 2/3 of people with mutations of the postsynaptic density, they're the ones who develop the regression. Look at this one you can't see, but actually this is embryonic mutations. If people have embryonic mutations, they have no regression because they were already delayed from year, -0 all the way up to 2. Like their delays were embryonic, right? So just so that you can understand the difference in this heterogeneous group of genes. So postsynaptic density, regression. And that is confirmed with SHANK3, right? And Phelan-McDermott syndrome, the classic gene to use to assess autism. That's a postsynaptic density gene. And it is a classic example of regression. They have one of the more violent types of regression where it really is startling to see. So I hope that we can understand that. And what's also important is when you have this, the parent looks for more. The parent wonders if it could be an environmental cause. So 71% of parents, if they have an autistic child with regression, think it's due to the environment. And so they'll be trying naturopathic stuff. The kid might come in with, weird medicine overdoses or go meet different people and try different therapies that are somewhat dangerous, even though it's still genetic, just like we were talking about. So that's important to sit down and consult them more and spend time on that topic. So to make conclusion 1 here, I wanted to distinguish autism regression, which is temporary social and language regression, from pediatric intellectual neurologic deterioration, PIND, which is, a true decline in milestones, loss of milestones, and then a new emergence of a neurologic deficit. So returning back to the kind of, pattern here, first we've ruled out non-genetic, got our LP, made sure it wasn't infectious or inflammatory. We ordered exome, but it's going to take a while to come back. And then the last step is ancillary studies while we wait. So for the exome piece, I don't think anybody has any reservations about exome. They know it's like the future and the direction we're going, but I want to justify it for us. So this is the old way. And by old, I mean 2014, a time when you all remember being the exact same as you currently are. This was only 10 years ago. You were all adults, it's like, but the way to work up PIND was completely different. It was inborn errors of metabolism, a battery of tests, right? And this is one of the better studies of this. First tier is, plasma amino acids, homocysteine, acylcarnitine, copper ceruloplasmin, organic acids, purines, pyrimidines, creatinine, metabolites, oligosaccharides, and glycosaminoglycans. The glycosaminoglycans and oligosaccharides we don't often do in our service, but we probably should, right? If we actually were doing this battery. But this will only detect 60% of inborn errors of metabolism. Then you do another 20 labs and you can get to 100% of treatable intellectual disability. The only problem is that is, $20,000, $50,000 work up, right? And how much is an exome? It's like $1,000, right? And these take weeks to come back. So this is a fossil. That's why I put the fossil there. they would run this in tandem with CGH and Fragile X. That was the old way. Now the new way is rapid exome. So it's actually recommended, and you can put it in your notes. Like, you can quote all of the systematic reviews to justify it so insurance doesn't screw you over and make it difficult. You can say, well, the American College of Medical Genetics actually says that for patients under 18 with intellectual disability, it's a first-line study. So would you prefer me to not do my first-line study? That's fine if you want me to waste the family's money, but I could do the standard of care and order exome. Right? So that's not even for regression. That's just for intellectual disability plateau, right? But with regression, you're damn right we're going to order this, pardon my language. So I wanted to impress that. So you'll order it, and exome actually comes with a CGH built into it. You just have to read the fine print of the company and make sure that it does it. So, you know, it'll have exome with the copy number variants. That's their way of saying CGH. If that doesn't find the diagnosis, then you can order a formal CGH. If that doesn't find it, then you can add ancillary testing. And then you'll revisit in 1 to 3 years. The pertinent part of this is that in a 1 to 3 year period, exome data may increase in yield by around 10%. Right? So you wait 3 years, you have a 10% increased likelihood of coming up with that diagnosis finally. So it is important to continue to follow your children who have an unexplained intellectual disability. Fragile X testing, metabolic testing, mitochondrial DNA, just think about whether you want to add those to your study. Mitochondrial DNA, if they have like multi-organ issues or eye problems, you know, metabolic testing, if it starts real early or it has that sort of, you know, exercise induced or some sort of, you know, component where increased metabolic stress results in the delay. And then Fragile X, because it is fairly common, but you need to see the craniofacial changes really to be prompted to do it. We're a little less gung-ho on first tier Fragile X testing than we used to be. And then karyotype actually for balanced chromosomal rearrangements, which don't show up on CGH and they don't show up on exome. So there's another possibility there. So in case you needed a little bit more, you know, evidence here. So exome yield was 36%, according to a lot of a meta-analysis. And if you add trio, which is you test the parents with it, and the child has some sort of congenital anomaly, then your yield goes up to about 50%. So you're, you know, compare that to the old test. It's not even a contest, right? CMA 15 to 20% if you're lucky. It depends on what you're looking for. And then I just want you guys to impress you guys to remember, did we test mitochondrial DNA, right? And then did we get DELs and dupes, you know, deletions and duplications tested when we ordered this? So for GeneDx, which is our popular brand, the one that we use, we actually run it in, if you run it in trio, roughly 10% increase to your yield. It catches copy number variants 2 or more exons. So remember, many exons make a protein, right? So actually, it'll detect a DEL or a dupe in less than the size of a gene to make a protein. So it's a pretty good resolution CGH built into the exome. But you should know that before you order your test. And then normal delivery for GeneDx, 6 weeks, and that's kind of across the board. Most places are like that. You can call them and rush it in 1 week. So there's no way you can tell me that like checking inborn errors of metabolism, which comes back in a week, is better than checking exome, which you can also get to come back in a week if you push, right? And then the cost of exome is between $800 and $1,500 out-of-pocket expense. Insurance will mark it up to way more, but like, talk about a good use of all of our money, right? If you wanted to spend a single, you know, your money on a single test just for your personal life, right? Like, there's nothing better than that test. But you might not like going through the results and consenting for what's going on and learning about a lot of these things, but it's very powerful. Fastest exome is 4 hours long. So shut up and take my money on this bad boy. So conclusion 2 is that exome is the first line for regression. So now we'll move on to ancillary studies. And I want to impress that, like, basically with ancillary studies, you could spend a separate grand rounds on each of these. So I'm going to kind of keep it short because adult learning and it's too much to talk about. But it breaks down into physical exam findings that help you, lead you towards a diagnosis. And then it breaks down into imaging, and it breaks down into EEG and labs. So you sent exome on your regressing child that you have, and it's going to take a week or two for it to come back. What do you do in the meantime? And I will leave you with three things that you should do. You should get the eye doctors to check the eyes. You should check sleep on an EEG. And I would say that the last thing is really that you should check for the physical exam and make sure that you're not missing anything. So in the patterns here, physical exam, some of the pictures we have here, if anybody remembers what this hair is an indication of, it's kind of like tight little curls, and the family has straight hair, but they've got really tight curls. It doesn't make sense. Minkies, yeah. And then this one up here is actually harder to know, but baby born with a whole bunch of dermatitis and red skin, and they've got some delays, a little low tone. And this one's a celeb shot, but it's biotinidase deficiency. And then over here, you can see this little like spot, even though we were trained to look at the the cup and the disc and not really over to the macula. That's why we need our buddies in ophtho to look, and they find a red spot there. And that could be an indication of what disease. Yeah, and there's actually several, because this process occurs in many conditions, but it guides your differential. And then you feel the belly and you notice that the liver is really big, but not necessarily strong. And what conditions have hepatomegaly?
Gaucher.
Mm-hmm. Exactly. Yeah. And so like that helps guide your differential. And then imaging, you're going to get an MRI on everybody, right? That was the third thing that needs to be done. So if you notice leukodystrophy, you can narrow your differential. If you have, involvement mostly in the front of the brain, right? That white matter tracts in the anteriorly. Remember Alexander, Dr. Barton always says that Alexander the Great comes first. He thinks highly of himself. So he would be in the front. And then what about if it's in the back of the brain? Yeah, because of the X. So X is the end of the alphabet, so it's in the back. And then, there are other patterns that I'm not going to discuss. EEG, we're going to go into a little more detail about, and then I'm not going to discuss the labs the old way, aside from what we've already done. So in terms of our job as neurologists, our job is to make sure that the EEG is safe, right? Like we're stewards of the electroencephalography. Like that's us. So someone else, we're technically covering other people's jobs with all the other stuff I talked about, but the imaging and the EEG, we need to be masters of. So there's an emergence of a new way to categorize developmental encephalopathy and epileptic encephalopathy that we need to understand. Did the seizures cause the child's delays, or did development and the genetic milieu cause the delays? Then the kid got epilepsy, right? Or is it a mix of both? So that's the gist between DE, DEE, and EE. Those are the differences. So, what do you see here? You've got a kid with trisomy 21, and then he develops, so he has delays at baseline, right? You can see it's flat. He has this delays. He develops spasms, which sometimes infantile spasms can be associated with developmental disability and regression. But you treat him and it doesn't change things. He's the same. So that is a developmental encephalopathy. He was encephalopathic before seizures and he stayed the same after, all right? So that's an important one that, most of them are that, right? Then there's the dual impact. So there are two examples of dual impact here. There's a myoclonic atonic epilepsy. Does anybody know the mainstay treatment for myoclonic atonic epilepsy? Bam, nice, good job. Yeah, that's super important because you can halt regression and actually flip some of it, but you won't bring them back to their baseline, right? So that's what it shows. It's basically a mixed picture, a dual impact. And then down here, you've got West syndrome. But this is West syndrome with an insult that happened. We'll say they had HIE or an intrauterine stroke, and then they developed spasms at 6 months old. So they were delayed already. Then they got spasms, right? So you treat them with steroids and it helps. And then you treat them with clobazam, valproic acid, and it helps. But as you can see, they're still worse than when they started, right? And I'll also point out that they develop LGS, right? And which is when seizures are so bad, you get developmental delay from it, and it's permanent. And then there's characteristic findings of LGS that we can talk about in diagnostic criteria, but they're outside the scope. So epileptic encephalopathy is the last one. And this is one that would be a darn shame to miss, right? Because if you treated it, you could potentially get their function fully back to baseline, bring their child right back. So the examples of this are continuous spike wave in sleep, Landau-Kleffner, which is can be a mutation of, does anybody remember? GRIN2A. So that can actually result in this phenotype. And then autoimmune encephalopathies are really important to rule out. NMDA receptor encephalitis is one that can really present with seizures in this type of picture. So CSWS, LKS, and autoimmune encephalitis. Keep those on your differential, right, for regression. Because if you treat them, they'll go back to normal, right? And you can't detect CSWS without sleep. So if you're dealing with true regression, you have to get sleep. You can't not get it. So I conclude now and give us 10 minutes for questions. This is for ancillary testing. I want to impress 3 things: that for every person with regression, they're going to need a continuous EEG that includes sleep at some point, especially if it fits the picture. Then they're going to need an ophthalmology consultation to formally assess other areas than what we're concerned about. You need the eye docs. And then an MRI of the brain is going to be necessary. You can add more after that, but I just want a kind of basic ancillary studies while you await for your exome to come. So in final summary here, autism regression is not the same as pediatric intellectual and neurological decline or degeneration. Those are 2 different things. You can parse them apart, right? We all now understand autism regression mode. It'll be only social and speech. And then it should, to an extent, come back at about 5. Lost at around 2, comes back at around 5. PIND is not like that. It keeps getting worse, and you get a focal finding. We should also understand that exome is tier 1 for regression. It is what you need to do, and you should understand whether it has mitochondria DNA sent with it. You just press a button to make it happen. It doesn't even necessarily cost more. You can press that button on there when you order it, and then understand the resolution of its copy number variant determination. And then the third thing is call the eye docs, capture sleep on the EEG, and always get an MRI. So that is everything about regression. Thank you very much. If anybody has any questions, it would be awesome. Love to hear it. What do you guys think? Could you get an exome on an adult? Have you ever tried? That's my question for you guys.
The question is here.
CJ, can you hear me?
Yes, I can.
Hey, it was a good talk, really good talk.
Great.
So here's a question. Is there any data that you found on individuals who have a prior insult and have intellectual disability that may seem out of proportion to that? insult and what the yield of exome and other tests is on that?
No, actually, that is a great point, and I did not find any particularly on that. They had tried in the autistic cohort, they did some determinations of what the extent of their delays were beforehand. And in every child with, for instance, autism, there's eye tracking abnormalities, like in most of them, that are really subtle and not noticed by caretakers. So at around 5 or 6 months, the first thing that you can notice in people who have basically, disorders of, of initiation of behaviors and social things like that, they notice eye tracking issues right away that only can be picked up on kind of like a machine learning algorithm camera of the eyes. So it's not actually something that humans easily pick up. But I didn't actually, nothing in particular for what you're saying aside from that. But that would be a good screener for kids. If we had that device, we could screen them at 6 months and pick up on developmental delays before family even does.
Yeah, I'm wondering more on kids, say, someone who is a premature baby and is expected to have delays because it has PVL and everything, but the clinical picture doesn't quite fit how much you would expect them to be delayed or regress over time. If there's any studies on that, on yield of further testing. Yeah.
Yeah, and maybe Dr. Brock is aware of something like that. But I'll look into it because that's a lot of our patients.
This is an excellent talk, CJ. You mentioned some of the biochemical tests as kind of being more, archaic or not necessarily having a huge role with exome, but are there any of those that you should get earlier while waiting for the exome because it makes a difference in terms of, how quickly we could get those back? Or what did you find in that regard?
Well, and I'd love to hear if others could weigh in on it as well, but ammonia should probably be ordered in everybody who's encephalopathic because you can make an immediate change to management and improve things. So ammonia is like a no-brainer. I would say that even higher yield ones like plasma aminos and urine organics, it's kind of hard to say. If you're reliably getting this back within a week, you'll be getting that back around the same time. You may want to know in general, is this mitochondrial versus, like urea cycle, which metabolite is impaired. So I think that if you're dealing with a newborn child, you may order those, metabolic tests, like basically the first tier here. But if you're dealing with somebody older, I don't think it's necessarily a good thing to jump on. The geneticist will still probably order it for you, but I would say as neurologists, it's a little less. I spend all your time working on the exome, getting it as fast as possible. Because, yeah. But anyone else have any thoughts on that? If you order 3 of these, it's more expensive than an exome. Just to think about that, right?
Hi, this is Disha. I had a question.
Yeah.
So if we have a patient and all the workup is negative and the exome sequence is negative as well, is there like a theory on what environmental factors are more, like, is it a mom having gestational diabetes during pregnancy or anything like that that has been studied to be a causative factor for autism?
It is, yeah. It is a causative factor. There's a lot of epidemiological factors that weigh in to the development of autism and also intellectual disability. And that is certainly one of them. Preterm delivery. I kind of think about it, and this is where it's just, me separating from the institutions, but like that if you have an increased burden of stress and inflammation during neurodevelopment, that predisposes the autistic phenotype. So there are certain, larger prevalent studies that kind of corroborate this. Preeclampsia increases the risk. Gestational diabetes increases the risk. A lack of breastfeeding seems to increase the risk. None of these are causal. They're all associative. So ultimately there's quite a few things that can you have a non-specific like environmental risk score, you know, based on your development, and then you have a polygenic risk score based on single nucleotide polymorphisms. And they actually do a terrible job of calculating either. Like there's almost no reliable testable way to calculate either. But just in terms of our thinking as we move forward, I think we should think about that. You know, like what is your overall environmental risk and your overall genetic risk? Can we calculate both and then predict your likelihood of getting autism?
Thank you.
Mm-hmm. Oh.
CJ.
Thank you. Thank you, Dr. Barton. I should just repeat the comment that Dr. Barton likes me. No. Any research or recommendation on when to refer these kids to neuropsych? Thank you. You should refer all of them to neuropsych. Yes. I would say that if it's in the acute phase of an illness, like you find autoimmune is a major component or something, you know, actually to wait until like not immediately while they're sick, but once they're home to get a test, and then you'll just know you have to retest them and later 6 months or a year to get it, you know, is their sick the new baseline, or is the new baseline, are they going to return to their prior? But yes, everybody needs neuropsych, because neuropsych also helps families figure out how their kid's going to learn going forward, and gives you metrics like the Vineland test, basically, would be a great one. Oh, and also you don't need to use necessarily neuropsych. You can do a psychiatric evaluation. They'll do the Vineland there too. We order neuropsych a lot, but think about that for when there's a structural issue that's causing their problem with learning. If there's no structural issue, you can just do normal psych. They might get it earlier, and you can get those results, you know, faster. Any other questions? So I will leave one comment here. You know, Dr. Brock was bringing up like that the world is not ready to do exome all the time. And that's the thing that we have to kind of keep in mind. So I'm giving praise to using exome, but you need a genetic counselor to talk through what this is. And so going rogue and doing it without getting that support would be, you know, a light form of malpractice, because you could cause harm to them and not consult them appropriately. Maybe they have a family, they didn't realize they have Huntington's and it wasn't going to manifest. And now they know, and they have distress and they kill themselves, you know, just like there's other examples, but like maybe they didn't want to know about their Alzheimer's risk score. Maybe they didn't want to know, you know, so they need to have maybe they wanted to be a pilot, and they learned from their genetic testing that they're no longer able to serve in the military or be a pilot, right? So there's quite a few things you have to consent appropriately. You can't just go rogue on ordering exome for everyone. It's an amazing test, but we need to get more genetic counselors. So everybody should think about, who's your genetic counselor? Do you have one in your practice? If so, maybe call them up and talk to them about, hey, what would it be like if I wanted to order exome in the future? Can I use your information and give it to the patient and see if they'd be okay with that?
Yeah, there's a lot of adult applications here too. There's a lot of, I was saying, a lot of adult applications here too. So even Dr. Plotty yesterday tried to ask me about how to get into our genetics for a patient she was suspicious of. I have people I've graduated with or other partners who always run into concern for loss or mitochondrial disorders, and it's always tricky for them to figure out how to order it and work this up. So these are nice principles to kind of hold on to too. A lot of these diseases we think about regression in the pediatric age group, right? But many of these disorders have adult onset. or adult onset presentation. So they're really good things to hold on to.
All right. Thanks everybody for your attention. Sorry for technical difficulties. Hopefully we learned something.
We learned to use that computer.
Yeah.